at these. We're talking about some functional radiosurgery. Ooh, really hot. So the functional radiosurgery targets that we're looking at, they're somewhat defined by radiographic assessment, either on a CT or an MR. And so I'll try to point. I didn't realize they were going to be so far off to the side, so if I don't point very well, I've also done some PowerPoint contouring for everybody today. I got the slide. So they were wondering if I was going to get the slide everybody else got. So stereotactic radiosurgery using sgrt. We're going to be talking about functional radiosurgery for trigeminal neuralgia and arteriovenous malformation, or AVMs. These treatments, but before we start, the gentleman down here, this is our SRS team at Centura. They do yeoman's work when it comes to the planning, a lot of the data you're going to see on some of our dedicated stereotactic units. And so I'd like to thank them before we even start, because a lot of this work wouldn't be possible without them. Disclosures, Vision RT was kind enough to bring me out here to talk about this. I also provide physics consultation services to both Varian and Vision RT for various things you'll see in the talk, and disclaimers. We're going to talk about vendors from a lot of different perspectives. This is not an endorsement of any one vendor. This is done across the United States using a number of different arrays of pieces of equipment. So our objectives is to look at the characteristics of stereotactic radiosurgery for treatments of non-malignant indications, things like trigeminal neuralgia, sphenopalatine ganglioma neuralgia, or SPG, arteriovenous malformations, or AVMs. All of these are non-malignant diseases. These are functional diseases related to pain management or treatment of a network of malformed blood vessels. And so we'll discuss how we treat these at Centura. The indications are relatively rare. You're talking, in the case of the fifth cranial nerve, the trigeminal neuralgia, the TN, and the SPGs, maybe 4 to 5 cases in every 100,000 population. We sometimes feel like they all live in Colorado because we treat a lot of these. But we do see quite a few of these patients. We'll discuss how we treat them at Centura, discuss the aspects of these treatments that are pertinent to SGRT specifically, because this is the SGRT meeting. Compare SGRT techniques to real-time imaging techniques, because a lot of times there's some critiques about SGRT, that's the surface, it's not an internal target. How do you rectify that? We've seen some triggered imaging talks, which is nice to see. We do that as well for our SBRTs. And then we'll look at patient targeting characteristics and how they can impact our approach to SRS in the future, how we can kind of fine-tune our approach to some of these types of treatments. And then some side missions, we're always looking to see how we can use our SGRT systems more effectively to increase the throughput, the efficiency of what we do, how we actually manage these patients. So we'll look at some of the treatment data and what it's actually telling us, and then contemplate how we can use that data in a more efficient way in the future. So trigeminal neuralgia, if you're not familiar with it, and the SPGs, both of these conditions are treatments of a dysfunction of the fifth cranial nerve called the trigeminal nerve. The nerve over here, the schematic that you see, it has 3 branches at the trigeminal ganglion. It goes into the ophthalmic branch, the maxillary branch, and the mandibular branch. SPGs are a dysfunction of the maxillary branch. Trigeminal neuralgia is essentially viewed as a whole complex issue. So it's treated at the root entry zone as it emerges or erupts from the pons. About 25% of these patients, at least in the case of trigeminal neuralgia, don't respond to medications. So they have no medical or medication-based way of managing their pain. 25% of those people, an additional 25%, will grow resistant to their medication over the course of their management. So you're talking about 50% of these patients have extreme pain associated with this dysfunction. There's a reason why trigeminal neuralgia got the kind of moniker of the suicide disorder. These is not a malignant disease, but these patients oftentimes will take their lives because of the fact that they can't manage their pain. And so we want to be able to provide some sort of relief to these patients. Some non-radiosurgical treatments for TN is microvascular decompression. A lot of times this is a mechanical impingement upon the nerve within the anterior pontine cistern, which we'll look at on a T2. There's radiofrequency ablation, which is probably the second most effective surgical intervention. Then there's balloon compressions, intravenous, anticonvulsive drugs, and glycerol injections. Those are very ineffective, but have shown some promise of working in some minor cases. For SPG, the interventions are largely an anesthetic block. So we're looking at in the base of skull, we're going to inject an anesthetic block into the nerve ganglion. or we'll use an anticonvulsive drug like gabapentin. But again, SPGs are more, instead of an electric shock type feeling across the entirety of your face, triggered by things like touching the face or brushing your teeth or something like that. SPG is more associated with low base of skull cluster headaches, pain of the hard and soft palate. So it's a little bit different, but again, very painful for the patient. Arteriovenous malformations, or AVMs, are also benign. The intracranial versions are basically abnormal, tangled interconnections of arteries and veins. So there's this poor blood flow or interruption of blood flow within the brain. There are approximately 10 to 15% of these patients have AVM symptoms. Many of them go undiagnosed until autopsy because they are prone to rupture because they are poorly differentiated type of blood vessel networks within the brain. So AVM symptoms based on vary of size and location. Functional brain eloquence around the AVM itself typically plays a role in the grading. So that does kind of, the grading is what we use to determine dose and how we approach these targets. Some of the symptoms are progressive loss of neurological function, headaches, nausea, vomiting, seizures, loss of consciousness, and then a lot of the intervention is basically surgical. Surgical is really the only way to guarantee a non-bleed risk after surgically addressing it, but it is subject to being a candidate for surgery and also being willing to accept some of the neurological deficit associated with the surgery of an AVM in a specific eloquent area of the brain. So, what we want to do, and they can also be partially embolized. Sometimes we treat these that have been partially embolized, so if they drain deep in the eloquent brain, they'll kind of embolize those, and then we'll treat kind of more of the periphery of the AVM. So radiosurgery, I don't know how this ever became a treatment for trigeminal neuralgia. Just if you think about it, you have extreme electrical shock type pains in the face, and we're like, hey, we're going to bolt a frame to your head. That doesn't seem like it would be a hard sell on a patient, but at Centura, we're doing these obviously frameless. We're doing this with sgrt. So the patient is receiving an MRI, typically a T1 and a T2 study, followed by a high-resolution CT, typically 0.5 millimeter to 1 millimeter in resolution. CT scans are done head neutral, favoring chin down because we are using sgrt. Our sgrt process always starts at SIM, as we've heard through many talks today. We move through that. Patient CT is sent to the treatment planning system. All the studies are fused. We plan 5 to 6 arcs using a 4 millimeter ICVI cone on a variant edge accelerator. So we're treating this with a 4 millimeter cone single shot right at the root entry zone of the trigeminal nerve. So as it erupts from the pons, there's about a 3 millimeter length of nerve that's about 1 millimeter in diameter. We're targeting that root entry zone with that plan with a single 90 gray shot, looking to cover about 0.3 cc's of the pons with about 20 gray. Some studies show that you can go up to 45 gray. The most common neurological symptom after this is some minor facial numbness. There's some cybernetic studies that listed facial hemiparalysis. We have never seen that with some of our radiosurgeries, but that has been also reported. After we're done planning, we push it to align RT. We do all of our pre-treatment QA, which is alignment verification using an optics only and a radiographically assisted Winston-Lutz. The ICVI cone alignment is verified radiographically. We do our own software that we basically guarantee the 4 millimeter cone satisfies the same targeting as the cone that's used as the reference cone for Winston-Lutz, because you can't do a Winston-Lutz with a 4 millimeter cone. And then we do some collision checking using the sgrt system. So what that looks like, this is my poor attempt at PowerPoint contouring. We have the brainstem on an MR. This is a T1 MR. You have the right trigeminal nerve as it erupts from the pons. We have the left trigeminal nerve in all 3 views. This is the T2, so you can see the white CSF in the anterior pontine cistern. You can see the blood vessels that are in the cistern. Those are typically the offenders when it comes to this, mechanically impinging upon the nerve. So again, the brainstem, we have the right trigeminal nerve, the left trigeminal nerve. We target the nerve just at that root entry zone. So in this case, we have 5 arcs using a 4 millimeter ICVI cone, delivering 90 gray to a single point. That dose distribution looks like this, with the brainstem, the nerve, and then this yellow area being the 20 gray line, just barely touching or just inside the pons. If we're talking the sphenopalatine ganglion neuralgia, or the SPGs, they're treated exactly the same way. So our process at Centura is to basically guarantee that the simulation, planning, and treatment is as standardized as possible. We're changing our targeting, obviously. We're changing some of our techniques. but we're probably keeping the same process. If you went and looked at a GBM or a whole brain, the process looks identical. We're just changing what we're doing in treatment planning. So we're doing, again, patient is receiving a high-resolution CT. In this case, we're not actually getting an MR because there's no soft tissue that we're targeting. We're actually targeting the pterygopalatine fossa. It's a tongue twister there. We call it the Vindian Canal, the mouth of the Vindian Canal. We're using 5 to 6 arcs again, this time with a 7.5 millimeter ICVI cone, because we're now treating a little bit larger area. We're targeting the bony fossa, so we don't need an MRI. The way the nerve comes through, it's off center line, so basically we're looking a little bit lateral and a little bit posterior within the Vindian Canal mouth is what we're targeting, and we're trying to cover the entire canal with the dose, so we're using a slightly larger cone. This is also a 90 gray shot in a single fraction. We are usually trying to center that dose in that canal, but we obviously have a neurosurgeon that's pointing out kind of where he would think that the nerve is kind of coming through that bony foramen. We don't do any modifications to either TN or SPGs for retreatment. So if you got 90 gray and gamma knife, you're coming back 2 years later, you're getting another 90 gray shot. And so there's no modifications to this protocol, whether you've had 1 previous treatment, 2 previous treatments, if you've had bilateral treatments, these are all done 90 gray single shot. After planning, again, SGRT systems pushed. We test everything with an optics only and a radiographically assisted Winston-Lutz to make sure everything's targeted correctly to sub-millimeter accuracy, ICVI cone alignment, because again, we're using a cone for delivery, and then a collision verification with the cone that we plan on using for treatment. What that looks like, this is the Vindian Canal. You can see where the crosshairs are slightly lateral and posterior in the mouth of the canal. We target that canal, there's no MRI. We have a dose distribution centered on that canal, which you see in red, and then you have a dose distribution that's slightly larger than your trigem, and that green area is essentially the 50% line that we're trying to encompass the entire bony foramen with the 90 gray centered on isocenter. Arteriovenous malformations, these patients, again, same exact thing. I'm trying to drive home the fact that we do not change our process. We're changing the way we plan these, but we're not changing the SGRT process. So the patient is, again, high-resolution CT scan. They're getting an MRI T1 with and without contrast, no T2. The reason for the T1 with contrast is we're looking to define as our target the AVM nidus, which is basically the cluster of blood vessels that are basically interlinking the veins and the arteries. And so some of them may have been embolized, some of them may have not, so we're looking for the contrast to define the nidus. If you're doing angiograms, if you guys, anybody who's treating these, some people will do a 2D to 3D fusion of an angiogram as well. Those are somewhat useful, but the 3D T1s are actually really nice. High-resolution CT scan, MRIs go to the planning system. These are very large, irregularly shaped structures, as you'll see in the next slide. So we're basically looking at the nidus being the GTV, which is equal to the CTV, which is equal to the PTV, which means that means zero margin. That makes absolutely no sense because we have a mechanical system. We know that, but neurosurgeons love 0 millimeter margin for these because it is a benign disorder. So we are using GTV equals CTV equals PTV. We'll talk about what the consequences of that is. We determine the dose based on, let's see here, this poor gentleman who I'm going to butcher his name here somewhere, right there. So I won't butcher his name, but there's a paper that shows the 3% risk for brain necrosis based on volume and local brain eloquence in the surrounding AVM. So we look at that table, we define based on the size and the maximum dimension of the AVM. We prescribe 100% to the surface of the AVM contour. After that, we go through plan approval, ship to the surface guided system. Again, optics only, radiographic Winston-Lutz, collision verification using the SGRT system, and then obviously now we're using a VMAT plan, so we're doing a VMAT dose verification. What that looks like, this is a very large AVM, about 8 centimeters. It has been embolized, but you can see on the T1, the nidus that's been defined by the neurosurgeons. This is a 4-arc VMAT SRS plan, 100% line, 50% line, and the delivery happens roughly for an AVM. You're talking about a 15-minute time slot to treat these patients. So it's an alignment with the SGRT system, cone beam CT, reference image, and then we monitor and shift off the SGRT throughout the course of treatment. Very, very quick. TN and SPG a little bit longer, 20 to 25 minutes, because you're delivering 90 gray through a 4 millimeter cone. That's a lot of monitor units you have to deal with. You're talking somewhere around 8,800 monitor units, something like that. So characteristics of these processes pertinent to SGRT, because we're an SGRT conference, we're not a neuro conference. It's really high dose is not something that we care about, honestly. As a medical physicist, I do not doubt that the output of my machine is correct on any given day. So I'm not worried about the output being wrong, but I'm actually worried about the high dose shot being 90 gray in 1 fraction. I don't get to come back and clean up my mistakes. And so the targeting ends up being of paramount importance. So the SGRT system is helping us align these patients to the root entry zone. Again, it's about a 3 millimeter long nerve, 1 millimeter in diameter. So any small misalignment results in a seriously a decrease in the dose at the periphery of the nerve, which then leads to poor effectiveness in the treatment. Doses for effectiveness published for TN and SPG are somewhere between 60 and 90 gray. Everything favors the higher end of the spectrum at 90 gray, so that's what we use. The dose falls is very steep, so obviously our positional errors are very, very important. In the case of AVMs, the margins, again, are 0 millimeters, and we may have parts of our target with 0 millimeter margin very far from isocenter. So we need to make sure that if we're going to protect the brain eloquent areas around the AVM, that we're accounting for what the SGRT system is telling us. How we do that, we look at the alignment accuracy of these systems. I've kind of updated this. This is a slide that's been around in my talk since 2014. These are the various different systems. These are kind of conglomeration reports throughout literature about approximately what the accuracy of these systems are. So basically, AlignRT, BrainLab frames, all around the same. Variant OGP, I keep it on there for historical purposes. It was the first optically guided platform on the market. Didn't have the greatest of accuracy, but was pseudo-stereotactic capable. CyberKnife, lots of different literature pointing to a lot of different things about a 0.8 millimeter. So everything's sub-millimeter, TG 142 compliant. SGRT allows us to do initial positioning. It allows us to do maintaining of positioning, so motion management. Allows us to take a reference of the cone beam CT, which is our gold standard. Allows us to reposition the patient if they move away from the cone beam CT, if we're properly commissioning and understanding what we're looking at. So if a patient moves during treatment, we can actually move them right back to the cone beam CT in 6 degrees of freedom without ever taking another image, if you feel comfortable doing so. Some of the critiques, the noise in the system, it is an optical system, it is subject to noise. It's been published on 1,000 times. I think it's largely been addressed. The noise in these systems are around 1/10 of a millimeter, so not something overly concerning. We've measured it and published on it. A lot of other authors have done that, the same thing. Camera blockage is a real issue if you combine it with poor simulation. We had another talk about poor simulation leading to results that we don't really expect. Poor simulation is kind of a systemic problem across the board in a lot of centers when you start doing SGRT, not realizing what impact that actually has on the quality of your treatment. So if we have head neutral or chin down. If you don't have head neutral or chin down, you have chin up. You have self-shadowing combined with camera blockage, which means that your cameras just can't see enough information. You need to be very careful about that. It is a real issue. Not internally based, so it is a surface-guided technology. There's plenty of SRS papers now showing SGRT being fine for SRS. I still hear this, though, as a consultant when I go places to do training, so people are concerned, what does this mean from an imaging standpoint? Advantages, it's extremely fast, limits the time on the table, which is the most important factor that we see continually published for patients moving during treatment. No imaging dose, published accuracy is better than 0.3 to 0.5 millimeters, and it's true real time. We're talking about 25 to 30 frames per second. So what does this SGRT data tell us? We know that we're accurate. This is a true isocentric type of reporting, so the data is reported around isocenter, not at targets distant from isocenter, so we need to address that. Margins and tolerances are largely adapted from historical purposes. 1 millimeter, 1 degree is fine for single isocenter, single target types of SRS, but does that really translate to things that are far away from isocenter? And can we use the SGRT data to better refine this? So at our institution, we're writing simulation software that assumes a target is basically a spherical volume. This is fine for trigeminal neuralgia and SPGs. We have the target radius and the coverage radius. The margin is 0 for an AVM, so M would be 0. So R and capital R or R and R prime are the same. We can easily simulate this. So basically we have 2 spheres. As we slide the spheres apart, or 3 spheres and we slide the spheres apart, we create this annulus volume that we can calculate the volume of. That is basically the RTOG conformity index that's published for SRS, or the overlap percentage of the dose with the target. So we can actually simulate this for all SGRT allowed tolerances. So we do this for something simple like a trigeminal neuralgia. single shot, 0 margin, root entry zone size of 0.3. We simulated. The top row, what you see is basically a distance graph. So it's a 3-dimensional distance away from isocenter. So there's 0 discrepancy between 2 targets that are overlapping perfectly at 0. And as you move them apart, the distance between them goes up. That should be relatively not controversial at this point. But the graph underneath, that is your dose fall-off. That's what the RTOG conformity index looks like for something like this. So very small shifts or misalignments in your position can decrease the dose drastically. So if we look at 70% coverage at 0.5 millimeter, so half the width of the nerve, that means we're giving about 60 gray. So a lot of the literature says, oh, it might be 60 gray, it might be 90 gray. It might be 60 gray if you have really good targeting because you have good results. It might be 90 gray because there's a little bit of slop in there and we're covering it. There is no, medically double-blind study of TM patients. It's hard to be like, hey, you might get randomized to no treatment. Enjoy the face pain. That nobody wants to be on placebo in those trials. And so we have this, but we can see that there's fall off. So if what we want to do is actually maybe increase the margin, so instead of doing a point dose to 90 gray, look at maybe a sphere of radius 0.5 millimeter, deliver that. Now in the bottom row, you see this darker center is a little bit larger. That means that we have 100% coverage at 0.5 millimeter, which is what we planned for. And we also have 94% coverage at 0.7 millimeter. That means we have 84.6 gray. So if we look at this, we can talk about publications that say, how well are you doing from a targeting standpoint with SGRT? Here's a gamma knife study saying if you've done it well, you've targeted well, you should see a radiographic enhancement of the nerve. Another one from 2001 saying the same thing. If you do a very good job, you should see this radiographic enhancement of the nerve. So what we want to do is see how well is SGRT doing for us. And so here's one of our trigeminal neuralgia patients. We did a left trigeminal neuralgia treatment. A couple months later, they come back and we do another MRI. And what do you know? We see the same radiographic enhancement. All done with SGRT, all done the alignment, all of the tracking, single cone beam CT, treatment time of about 20 minutes instead of about 45 to 50 minutes. So not bad for the patient. They're in an open face mask, but they are experiencing pain, so we're trying to limit the amount of time that they're in the mask. This is not a trigeminal neuralgia patient, but this is a 4 millimeter pontine met. Actually, it's in the vermis next to the fourth ventricular section of the vermis. And you can see here, same thing, 4 millimeter cone, center punch the lesion. We have a DTI scan in the upper right, a standard T1 and a T2. You can see no radiographic scarring of the brainstem. This patient was treated in a 15-minute time slot and sent home. So extremely accurate from an SGRT standpoint. We have radiographic evidence that these things are more than adequate for treating these functional cases. Talking about AVMs, it's a little bit different. We're talking about a large irregular target with sections of the target or subvolumes of the target that are very, very far from isocenter when compared to something like trigeminal neuralgia or SPG. So we want to know, well, what are the impacts of setting an SGRT tolerance of 1 millimeter, 1 degree, or 0.5 millimeter, 0.5 degree at isocenter, because that's where my deltas within a liner T are being reported. So we, again, enter this information into a simulation. This has basically ramifications. If you could raise your hands, if you're doing single isocenter multi-target SRS. Anybody in here? Right, we got some brave people, cool. All right, so this has ramifications for that. So if you're doing a single isocenter and you have multiple targets all over the brain, you have to account for the leverage effect, the distance away from isocenter. All of our tolerances in SGRT are defined at isocenter though. So what does that mean for our targets? We don't have these fancy little clouds of dose that looks like spheres, we have other things. And so what we did, we have another web-based simulation package where you pick a target, in this case, a 1 centimeter target, 0 millimeter margin, pretending like I am putting on my neurosurgeon hat and my machine has no mechanical slop in it. I'm going to do 0 margin. I'm going to define how far away it is, 5.2 centimeters away from isocenter. I'm going to tell it its relative position. So we divide up the volume into a Euclidean geometry. So we have 8 octants that you're used to seeing. So plus, plus, plus would be plus X, plus Y, plus Z. So you're just giving it a relative position from isocenter. You're also setting in the simulation your SGRT tolerances. So in this case, I want 1 millimeter tolerances. So 1 millimeter, 1 degree. I also have the sampling resolution. So I'm sampling the translational motions at 1/10 of a millimeter. I'm sampling the rotational dimensions at 1/8 of a degree. The reason for that is this number down here is just for me as the programmer of this, telling me that I have an insane number of solutions, 45.5 million solutions for that set of tolerances at that resolution. So I have to calculate all those transformations, calculate the displacement of the targets, put all that back into the simulation and see what the cloud of possibilities looks like. I also know that I don't have the same probability of all these permutations of position. So if you look at your SGRT on an SRS, you're going to be watching your patient, and everybody's usually crowded around your SGRT system, staring at the deltas, hoping to God that they don't get close to the edges because you don't want to have to stop and reimage. You usually don't see a lot of rotational uncertainties reaching out to 1 degree. There's not a lot of craziness happening, unless your mask may be poorly made. I don't know what your simulation process is like, but we don't typically see 1 degree of rotation just popping up during our treatments. So what you can do is you can set these probability distributions. So this is for the pitch. Low probabilities at 1 degree, so basically 0 probability of seeing a 1 degree rotation during treatment once I've corrected with cone beam CT and took a reference. This one is actually a flat probability. If you look at the bottom, this is 1 at the top, 1 here. This is 0.99995. My software, I'm not a programmer, it just scales it so it looks like a parabola to remind me that that's still a probability distribution. But essentially, you can assign these probability distributions as guesses based on your experience, however you want to do it. Or you can actually, this came from a white paper that we published in 2014, 15, something like that. You can actually measure these probabilities. You can take an anthropomorphic phantom, set them up in the simulation position, place isocenters all over the cranial vault, monitor that phantom, and actually get your probability distributions for all of your degrees of freedom based on the location of the isocenter within the cranial vault. Super easy to measure. Takes like an afternoon of about an hour, hour and a half. You can get all these probability distributions, put them back in here so you actually have real data. You can guess at it. You can just guess everything has 100% probability across your tolerance. It doesn't really matter. Once you run the simulation, you find that at 5.2 centimeters away, you have this really funky looking shape. It's actually a sphere that lives on the surface of a sphere that is confined by another sphere. So for those geometry nerds out there, super cool. For those of you who don't care, who's staring at me like you, like, don't care. I thought that was pretty cool. So this is what your distribution looks like. These are all the probable positions that you're allowing for in your SGRT. When I say I'm setting 1 millimeter, 1 degree, that's what I'm saying I'm willing to accept. Simulation tells us that we basically need a 3.1 millimeter margin to cover all of those possibilities, and I'm using 0. And so maybe I'm not covering all of those. I can also filter this by the probabilities. So in this case, I told it the translational motions have higher probabilities. The rotational offsets have low probabilities. That makes a cube because I'm only moving in straight lines. So I should see a cube. If I filter at 50% probability, I can see cubes start showing up out on these spheres. And I only need a 2 millimeter margin to cover this. So if I only want to cover the most probable positions for my target at 1 millimeter, 1 degree, I only need a 2 millimeter margin. So you can start making decisions based on your SGRT data that enhances the way you treat these functional diseases. So if you're very close to an eloquent region of the brain and you're using 0 millimeter margin, you're going to need to kind of skimp on your dose at the surface of the target because doses that far away are going to actually ride into those eloquent regions of the brain. You can also say, I want to look at what my coverage statistic is. So this is 95% coverage. It looks like a sphere. It should look like a sphere because we're using spherical targets. You can also say, I'm going to use a 2 millimeter margin, then show me all of the probable positions. So now 2 millimeter margin tells me that I have 100% coverage on almost all of my points, and my lowest possible coverage miss is about 6%. So I have a 94% or a 95% coverage is my minimum. Now, if I filter the probability and say I only want things that are more than 10% probable, I bet you all of these outlier points go away. So maybe a 2 millimeter margin covers 99% of the points I care about. And so now you can start making intelligent decisions when you're doing a single isocenter multi-met or an AVM that has a branch that's 9 centimeters away from isocenter. You can actually create margin and do plans where you don't have to sweat over, should we stop and should we image? Should we image between every beam? I'm not really sure what to do. You can know before you go into the treatment. And now the treatment can be 15 minutes instead of 45 minutes. So there's interesting things we can do with SGRT data. That seems like a lot of things to do for a lot of busy people in clinics. You probably don't want to do that. But if you wanted to do it, SGRT gives you all of the information you need at the tolerances you want to set if you're willing to put in the work. But maybe SGRT isn't the answer. That's where Norman usually falls over somewhere. No, there he is. SGRT does a great job. But what we want to do is compare this. One of the things that we wanted to look at is there's real-time imaging dedicated units now. What if we could put a completely isocentric treatment, move all sub-volumes of a large target, to isocenter so we don't have to worry about all these uncertainties, and then we could image in real time or pseudo real time and position the patient on the fly with internal imaging. We're not worrying about the surface of the patient anymore. Would that make it better than sgrt? Would they give us different results? We don't know. So at Centura, we have a Zapex. So this is exactly what we're talking about. It can move all of the subvolumes to isocenter, has a 45 SAD, 3 MV beam, treats just like a gamma knife, supposed to be a little bit faster, but also has real-time imaging. I always wonder what this rabbit is thinking, because when I walk in there, I think it looks like a spaceship. So to him, I just blew that rabbit's mind. And so the way we simulate for this, we have a Zapex couch-top simulator. You have to put it on top of your sim. You sim it. The goal is to get the patient as low and as high as you can. So we use the AlCare mold care cushions to move the patient as high up on the table as possible so we don't limit our beam approaches. We use full face masks. Unfortunately, there is no sgrt in this system, so we have to rely on mechanically and rigidly adhering the patient to the table. We can do trigeminal neuralgia treatments. Dose distribution looks pretty good, but if you look at the beam arrangements, which are the rays that you see up here in the corner, all of them are going through their face, less than ideal. But that is part of the design of the Zapex. They're addressing that by readjusting the design of the couch to a proton couch, which should give us more posterior beams. Same thing, SPG, mostly through the face. They say you have 2 pi solutions. You actually have about pi solutions, and half of that if you're really super lucky. Dose distribution looks really great gradient because you're dealing with basically gamma knife energies. AVM, this is an AVM we actually treated last week. This AVM took 16 isocenters to treat, and it's relatively small. You're talking about someone being inside the Zapex for about an hour and a half to hour and 45 minutes, opposed to a 15-minute treatment. So some of this comes at a cost for these patients. You have to be inside the Zapex for quite a while because you're now treating all the subvolumes at isocenter. This is how many beams we could get on a AVM. So a lot more beams, a lot more solution, very tight gradients, looks really nice. This is the TrueBeam or the Zapex console. You load the patient. This is actually one of our pseudo-anthropomorphic phantoms. You go through an auto alignment. It auto aligns the patient. It has 3 degrees of freedom that simulates 5. So you have yaw, pitch, and long, because those were the 3 I would pick. But if you want to go ant or post, you're doing basically pitches and longs, or if you want to go left, right, you're doing yaws and longs to accomplish that. You cannot correct for roll, so that's not a possibility. But you do your alignments, you get pseudo 5D alignment, you verify the alignment, and then you say, I am ready to treat. It says, okay, if you're ready to treat, I'm going to take an image because I'm a live imaging system. The first thing it does is image and move away from your alignment. It's usually about 1/10 of a millimeter, 2/10 of a millimeter, but that's because of the noise in the system. You're rapidly taking images, so you're generating DRRs on the fly. The cost of that is having low resolution DRRs, which means you have to filter the DRRs, then you have to register the DRRs and enhance the DRRs and renormalize. There's a lot that goes into these fusion algorithms, so there's noise. You're getting about a 1 to 2/10 in noise, and that's always seen on that first image. You then start delivering on the left-hand side. I believe that's the left hand for you. You see the live MV imaging of the Winston Let's target ball, but you also see in the bottom right corner here, in the white area, the plot of the real-time imaging shifts. So if we quickly go through here, you can see that it takes an image, moves, takes an image. Now it's moving in all 3 dimensions away from each other. I'm pretty sure my phantom's not moving. I can't guarantee it, but I'm pretty sure it's not moving. It moves again. It moves again. So when people are talking about noise in a system, the noise in the system comes from trade-offs that we're making. So in this case, on a phantom, we're moving about 0.6 of a millimeter as we move around the phantom and take images from different positions. We have a panel right here. This is the KV panel, and the KV source is under the patient at all times, and this panel travels within the cone of that X-ray source. And so you're getting different projections. The panel's tilted at 13.5 degrees. There's a lot of things going on that adds noise and uncertainty to these image fusions. They're all sub-millimeter. There's nothing wrong with this, but this is not the gold standard that we think we want when we say we want real-time imaging. We think internal imaging should be perfect because we have the idea that cone beam CT is our gold standard, and it should always be perfect. It's never wrong. And so this is what we were dealing with during commissioning, obviously well within the tolerances for SRS, so nothing wrong with the Zapex. This is our AVM last week. And this is an example of why you have to watch. So we load the patient into the ZapX, which is like going into a little submarine. We start the treatment, and you can see on the graph that he immediately went from aligned to it moved in the first image, moved back to the 0 line. This is the reference line. So we have it moved, it then moved again, kind of stayed around 0, and then all of a sudden you have this deviation. So you have essentially a deviation of roughly 0.8 of a millimeter from one image to the next. And that's because of the projection we're dealing with and the quality of the DRR. We're no longer dealing with a phantom, we're dealing with this bony skull base, and so we're getting a lot of noise in the image. We have to renormalize the image and smooth it, and he's also wearing a mask that has high frequencies because we have a lot of holes in our oculoplast mask. So we're adding a lot of noise to the image. We have to watch these numbers. These are the residual rotational shifts that cannot be corrected by the system. If they go over 1 degree, we stop, because what ends up happening is you start seeing wild swings in these shifts, and then you know that's not correct. So we have to watch these residual shifts every time you do a transitional alignment to make sure they stay below 1 degree. So what does this mean? Overall, with our experience right now with ZapX, we have Align RT here, we have ZapX here. So we added real-time imaging, we compared it back to sgrt, we've compared sgrt to all of our gold standards like Gamma Knife and Frames and CyberKnife and BrainLab and Variant OGP, and we're all getting kind of around the same area. So what we've learned through this is, I like this Mo technology, Mo problems. You can add more technology to everything. That doesn't necessarily you're making it better. Things come at a cost. Speed comes at a cost of resolution. We're getting 10 to 45 second images. So every time we get an image, it's about 10 to 45 seconds to process those. That's different than 25 frames per second. And I like the 25 frames per second because I'm an sgrt kind of guy. Subject to reference quality, your DRRs have to be low quality because you need them very quickly. And the different impact on noise is seen in the algorithm that they choose to do the fusion on. Accuracy is just a number, depends on how you measure it as the physicist. You'll learn that, you go through, you measure on a Winston-Lotz phantom, you can get things really, really tight. Never treated a Winston-Lotz phantom for trigeminal neuralgia, but I bet you I could crush it. And so that's the one that I'm really confident on. Live patients, you have to actually take into account the things that are actually happening. sgrt systems on modern Linux are more than capable than a lot of the things that we've used in the past. There's frame studies showing that frames have inaccuracies up to and including 2 millimeters because of the resolution of the imaging that we're using and the sag in the frame. So sgrt systems are more than capable to do these functional radiosurgery cases and do them extremely quickly compared to a lot of the other modalities. And then regardless of the technology, whatever SRS system that you're using for these functional cases with these no margins, you really need to understand the underlying principle that the vendor's using to do the fusions, to do the underlying technology, the way it's implemented, and then also how you're actually interpreting the data. If things are set up to interpret on isocenter and you're treating something way away from isocenter, you need to understand how that's working. So, end of the day, functional neurosurgery talk, everybody is thrilled it's over with. So.